Welcome everyone to the DRC Evacuation Focus Area session, the last session of DRC. We cannot thank you enough for being here. We've made it. Congratulations. So today's topic is going to be what we've built together and how can we carry it forward. So while we get started, wanted to do something a little different today. Wanted to do an icebreaker. We've never really done this before, other than tell us your name and where you're from. Um, but let's try this, and you will see a little bit as we go through. It's two birds, one seed kind of thing. So in the last week, you can type this in the chat. In the last week, what is something you've gathered strength from? What is something that you've struggled with? And or what is something that has surprised you? So as you all start typing, I'm going to go ahead and answer just verbally. Something that I have gathered strength from are my coworkers throughout PPN, the COEs, from the coalition. All of my coworkers have really come together. They've been excited about DRC coming to its last couple of sessions, but we've also been very sad. And the thought process that has gone with this has been amazing. Like, we've offered them so much. Have we offered them enough? How can we tell? Everybody wants this, not the DRC, this. Everybody that I work with and have come into contact during this time wants you all to succeed. They want all the hospitals across the country to succeed in preparing for a disaster. And that has really brought strength, given me strength in the last week. So that's my one. You can answer one question or you can answer all three of them. So go ahead and type those in the chat as we move forward. So before we get too far into it, I'll let you know the Pediatric Pandemic Network is supported in part by the Health Resources and Services Administration of the U.S. Department of Health and Human Services as a part of cooperative agreements. However, the content presented today is that of the authors and does not necessarily represent the official views of, nor an endorsement by HRSA, HHS, or the U.S. government. We are going to be offering CEs for today's session. You must attend the entire live session. You need to make sure that you complete the session evaluation at the end and ensure your name is on the session registration. So if you are borrowing somebody else's registration, go ahead and type your name in the chat, and or just rename your little Hollywood square. If you hover over your square on the top right and the three little dots, click that, click rename, and then you can rename yourself. A little housekeeping. Again, we are pleased that you're with us. We thank you for sticking with us and for joining. And we sincerely hope that you have gotten as much out of this as we have. We will be recording today's session along with the past sessions and posting them on our website. If you have questions at any time, please feel free to put those in the chat. You will also notice that I've left the allowance for participants to come off mute. So throughout today's session, we're going to be more interactive. So just know that you can come off mute. So I say that in warning and awareness. We are going to offer education credits. MOC Part 4 is available for physicians. So if you are a physician or know of a physician that has been doing this DRC work on your team and would like that MOC Part 4 credit, email the DNC PPN email, and I'll put that in the chat, and we can get you the information for that. The current priorities right now for DRC, hopefully you have done your first drill. You should have an email with Drill 1 data collection survey link in that email. If not, you can send me a message at DNCPPN, and I will get that link for you. You should be working on your drill number 2, the follow-up drill. And if you have, if you've done your first drill, you've done the first drill data collection survey, and now you've done the drill 2, you should be getting or have in your inbox a drill 2 data collection survey. So you can be looking for that. So for today's session, our objectives. By the end of today, you will hopefully be able to reflect on key lessons learned from the past evacuation sessions, identify changes implemented and current readiness capabilities, recognize barriers and opportunities to sustain progress, strengthen connections to support ongoing collaboration beyond DRC. Here's our agenda. We're going to do a little reflection and review. We've got some poll questions for you. Then we're going to break out and talk about what's been done and share ideas and barriers. And then we're going to talk a little bit about sustainability. In the surge session just before this, we really talked a lot about we've done the drill, we've done the work, it's not done. We have to keep going in this continuous process improvement. And so we'll talk about that at the end as well. And then we've got some really exciting next steps and closing that we'll go over as well. And with that, let's start working on or talking about series reflection and review. I'll hand it to you.
I can't believe that we're at our last team session. That's crazy. And I love some of the comments that folks have been putting in the chat. So if you have not had an opportunity to read some of your colleagues' comments, there's some really heartwarming ones, and perhaps some of them are familiar to you. There's some like ones in the chat. So let us look back at what we've done. Maybe next slide, Julie. So if we think about what we have covered during the course of this series, we've covered a lot. And remember, more importantly, we've talked about some meaningful insights that I think we termed nuggets right at the very beginning. Remember, we started with Chicken Little and talked about those golden eggs or those golden nuggets. And some of the ones that we have talked about, and Pat, I always think of you when I say this, but hospitals are built to defend, right? Not to evacuate. And that was something that we've mentioned a lot in our sessions. The other nuggets that are there are evacuation equipment rarely performs as expected, and adaptability is essential. And Pat also led us into some conversations around that. Communication breaks before systems do. So that structured communication like the LCAN or the SBAR we talked about really makes a difference. That we'll never have enough stuff, space, equipment, all of it, right? Those big S's that we talk about. So prioritization becomes really critical. So kind of thinking what is actually needed and what we can do with what we've got. Which goes into that improvisation is inevitable, but it should be informed, not random. We talked a little bit about that in one of our very last sessions. We also talked about the essential nature of external partners and that relationships have to be built before something terrible happens, before that dark sky day. And then we've actually talked quite a bit about behavioral health and pediatric considerations and that they require really intentional planning. We've heard some really great things around that, and they don't just fit into the adult systems. And of course, all those that have worked with peds for a while know that, right? We chatted in one of our last sessions about leadership engagement, and some of you have mentioned some of this in the chat for good and for bad. And that C-suite level really changes everything. And if they can understand the risk, that movement forward happens into some of these initiatives. So the C-suite engagement is really important. And then real learning happens when we move from discussion to application, right? So we've discussed a lot in this series, but then making those baby steps and then those bigger steps is really important to carry this work forward. I think next slide, Julie. All right, there's going to be three of us tackle this one just because you need to hear from Pat and Abby too. And so Pat is going to take struggle, and we'll start with Abby, who will take strength.
Good afternoon, y'all. I'm gonna echo them first. I cannot believe this is almost the end of our journey. And it's been wonderful to have you all with us. Um, yeah, so to talk about strength, I don't know if any of you all are like me. I think sometimes I have a hard time talking about my own strengths. But it took a lot of strength, I think, for all of you all to sign up for this collaborative. There's a quote from one of my favorite books that I thought was really relevant to this. The book is called Boy, the Mole, the Fox, and the Horse. And I definitely recommend checking it out. It's kind of short, but it's got some just really wonderful some points in it. Um, and I've lost it now. But so the quote is, "When have you been at your strongest?" And the horse answers, "When I have dared to show my weakness." I think that's really applicable here because it's easy for someone to say, "Oh, I'm strong and I've got this," but it takes a really brave person to show their weaknesses and say, "Hey, I think I've got stuff to work on," which is obviously what drove everyone to this collaborative in the first place. So I applaud your strength for coming and joining collaboratives like this to learn more. But we want to hear from you all. What has gone well? And why do you think that things have worked well for you? Does anybody want to give us a little nugget? You're gonna make us call on you.
I loved how you used the word nugget, Abby.
Nugget. I call my second kid, we called him Nugget because he was a little chunk of a thing.
If you're too shy to come off chat, to come up to verbalize it, you can put it in chat too, and then we'll read it to everybody with your name. I'm just kidding.
So I'll start, I'll throw it out. I think that part of the strength that I now think all of us share is our network. We were talking about this just prior to jumping on, but what we share now is that we all have a network of other folks who are in the same positions and who have struggled maybe with the same things, but have learned different lessons, who've gone through different struggles than us. And we all bring a different perspective and something different to the table. And so what we now have is what we were calling it earlier, everybody knows that guy, right? We've all got a guy to call. Um, I've got a problem with getting, patients downstairs. Well, let me call this guy because they had this same problem. Um, so now we've all had the strength of having that guy to call. But again, somebody give me something that you've got. Don't make us be the only ones talking. Your voices are wonderful. Allison says working well is getting people to see pediatrics has special considerations that should be reviewed when doing disaster planning. Amen. And yeah, I think sometimes that's the biggest hurdle to cross, right? And you've really done a good job if you can just get them to open their eyes and see that pediatrics are around and they have to be prepared for them, um, and that it is something different to prepare for.
I think the biggest aha with that, this is Allison, was we were doing kind of a reunification drill at our site. It was a tabletop exercise. And those who have either never worked with kids or do not have children of their own, we talked about like the importance, and we kind of talked about it in the meeting before, the panic parents may face during like disasters and reunification, and if how much bandwidth it would take to handle calls just coming in if a disaster would occur and you're reunifying children, and just the light bulbs going on of like, oh wow, we should probably create like a call center and get that out so that these families have just something that they can do, because you lose that, you want that some piece of control as a parent to know where your kid's at, and it's a scary feeling. So I thought that was kind of eye-opening.
Absolutely. Tanya said having a policy to test is exciting. Again, knowing that pediatrics have special considerations, absolutely. Just having any organization that just has a pediatric policy is a huge strength. It's amazing the number that don't, and then, again, having to convince them that they should, right?
And I'll add to that, actually, if you don't mind, because I work in a combined center, and a lot of times they totally forget about the pediatric population when they're making all the plans. So they'll put something into place, and then they'll be like, oh, well, we didn't think about the kids. So it's like, well, you have to think about the kids.
Right. Yeah, I feel like the pediatric population is that everybody thinks that someone else is going to take care of the kids, right? So nobody really remembers to intentionally plan for them, which again is why we're all here, to make sure that they're intentionally put in there. Regina said it worked well for us to choose a focus area that we felt had not gotten adequate attention in the past, and to intentionally choose a means of improving our evacuation process. That's awesome. And again, I think it says something about the groups that chose, that chose to join the DRC to start with, but that you are able to look inside at your organizations and see we do need to improve, and be open to improving and to seeing where you could improve, and ask for help from outside. I think that's a huge, huge win for everyone. Thanks, Kimberly. That's awesome. Kimberly says the resources on DRC website have been a huge strength to improving our plans. So kudos to Miss Julie and the team.
Yeah, I'll just say honestly, every day I feel I'm looking at that resource hub to just see what else I can, try to persuade, our campus to consider. So that resource hub is invaluable. So thank you for that.
Awesome. I'm going to shift it over to Pat and let us talk about struggles for a little bit. Get us off the struggle bus, Pat.
I don't know. It sounds like people were actually reporting some of their challenges associated with this. So, as someone who I think I've shared this previously, but I spent my career over 35 years in pediatric hospitals, and in nursing education, and being transport nurse and NICU and ICU, and just a whole variety of different types of roles, including being a nurse practitioner. Part of my job of being a nurse educator was to teach people what to do in a disaster. And we had our annual review, and we had our policies and procedures, and it was not until I left the healthcare sector and moved over to public health and emergency medical services that I really began my education in terms of disaster preparedness and readiness. And because I had all this background in pediatrics, I was able to bring to the table in those roles, those very new roles to me, what I could to help my community. And this is a shared, these struggles are shared. Okay. So when I first did this work, I actually did a walkabout to the 8 hospitals and the 8 to 10 different EMS agencies, and sat down with them and talked to them about, pediatrics and what they had in place. And every single entity reported that their biggest fear was to have a mass casualty for children. Now, that was in 2015. Now, we have made some really great strides, and there's been a lot of struggles, and there's been a lot of lived experience along the way, and we've had these collaboratives and now, but the struggles remain the same in many, many cases. This is very hard work to do. And the fact that you guys have chose evacuation as your the challenge that you wanted to tackle is an enormous credit to you guys, because it's one of the most difficult things to sort out and to approach for so many different reasons that you have interacted. So what I'd like to throw out there is that, what challenges do you think you made progress in over the last, over the collaborative? Where do you think, what topic? Somebody mentioned reunification, for instance, and various resources, but how are you using those resources? And what have you been able to operationalize as far as that's concerned? Now, that may be just as simple as showing up to a healthcare coalition meeting, or meeting your emergency manager and getting to know them within your facility, or your facility's people, in your facility, and learning what they know. Because we really need so much information and so much of that, lived experience and subject matter expertise, that other people in your organization actually have those answers, but it's like, you're the change agent. How are you going to bring them together? And so those are the biggest opportunities in these struggles. I look at struggles as being challenges, but also opportunities to face. So any thoughts about that?
While people are rushing to unmute, I'm gonna point out Kim's comment in the chat, that her struggle with feeling heard and communicating well enough to make a change, and surprised by how much work there is to do. And Kim, I hope you don't mind me picking on you, but the comment in the chat really kind of touched my heart, because this is, like Pat said, it's hard work, and it's pretty thankless until there's a disaster.
Yeah, no, I don't mind being, it's been a journey, in this position, kind of collaborating with our adult partners, really getting them to hear and understand why I'm pushing for change on all of these policies that have been in place for so many years, and why suddenly I'm, trying to upheaval and change things by adding pediatric aspects into all of these plans and policies. So, just trying to communicate properly and making sure everybody hears the why behind it. It's been a struggle to make sure that they're hearing me and why, and I have a lot of support. And then just knowing how much work is actually to be done when they do agree and finally, say, okay, let's amend this plan. But to Patricia's question and answer in what we've done, here in our campus, at Advocate Children's, we've done a lot with evacuation. We're working on our chain of command and how we communicate. We're working on go bags to grab in an emergency that sit at the bedside. Our hospital, all of our departments have really taken an interest in the equipment that's on their unit that's been dusty and, sitting without a manual, and none of them know what to do with it. So I actually have some work groups happening on different departments that are, there to educate their teams on this equipment for evacuation. And there's been a lot of interest from the frontline staff because they see the need. And so really just finding the champions that are really interested and giving them the opportunity to just go for it and build something. And then we'll come back and see what we can give, to the whole hospital. There's a lot of work happening, and it's nice to have a lot of interest.
That's terrific, Kim. I really appreciate that. I'd like to hear from any other people who have traveled this journey, because it is a journey as far as that's concerned. And these things happen in baby steps. It doesn't happen overnight. It happens in baby steps. And you just kind of chip away at it. But I will tell you that there will always be these windows of opportunity, even if you don't feel like you're making that much progress at this point in time. Unfortunately, some of those windows of opportunity are due to real world events. But if you have in your, hip pocket, basically certain things you want to get accomplished, when those windows of opportunity open, there is you really have to be prepared to run as hard and fast as you can through that window of opportunity, because the windows don't stay open very long. The whole reason we have the Pediatric Pandemic Network and, the Pediatric Disaster Centers of Excellence and us all coming together is because a window of opportunity was created to focus on this. So it's up to all of us, and especially all of you in your communities, to, look for those windows of opportunity so that, you can, cross your T's and dot your I's, a few more dots on your I's and a few more T's crossed along the way. Anybody have any success stories or any examples of, a window of opportunity opening and then having to, and taking advantage of that? Don't be shy. We're all learning from each other.
It went quiet on you, Pat.
I know.
It makes me want to bring up that quote, that never waste a good disaster, because we've had certainly plenty of real worlds, right? That we
Right.
have an opportunity to both observe and to learn from, and then to update our plans and make changes. I know that even in the course of the DRC, some of the things that we've talked about has had some forward movement based on the disasters that have occurred since we started this collaborative. And so that's both exciting and horrifying, right? But we do have an opportunity to use real world in our stories to our leadership and to our C-suites, so that we can get money and funding and support for these initiatives, because they do take all of that.
Sorry, I'm looking for the hand raise button. I can't find one, so I'll just jump in. But here at Advocate Children's, we've been using real world, the weather changes. So going from 30 degrees one day to 70 degrees the next day. And then all the problems we're having with chillers or getting the heat back on and just going day by day. It's really, when we did our evacuation drill, that was our scenario, was that the babies in the NICU were not tolerating this up and down. The chiller had gone out when we had, a really hot day. So it was just really bringing back, here in Chicago, our weather is up and down, and it really can impact the facility. So just bringing real life discussion to the drill was eye-opening for them.
Yeah, I mean, the disaster readiness really has to do with maintaining your continuity of operations and understanding, what could potentially disrupt those things, and knowing what options you have to either reduce those threats or to respond to them at the time. And the more we can do in the everyday, and this is why the whole pediatric readiness project that is going on, which I hope all of your hospitals are doing your PEDS readiness assessment again. But that is the whole reason that readiness assessment is part of the foundation of your of every hospital's opportunity to improve the care for children. Because if we can do it in the everyday, again, we don't have to fight so hard for demonstrating why kids are important to plan for them in disaster. Any other thoughts? Otherwise, we'll move on to Annette.
I get to finish this out with surprise. Woohoo, surprise. So is there anything that you found didn't go the way you expected? Something that really kind of shifted how you thought about evacuation planning, that was like that big aha moment? It's like a light bulb came on and you were like, oh man, yes, that. Anne, you got your hand up. What was your aha?
There was one big aha moment. I've been so impressed by like the leads that we have, including PEDS, because we are a pediatric hospital within an adult hospital, and the amount of policy, procedures, all of these things that have been made, and to be inclusive, which was a huge win. But we had a real life small event, thankfully, that involved mainly children. And for me, the surprise was that it was still very adult driven. They're like, well, we're not calling an MCI. I'm like, but we are already at capacity in our PEDS. We need to push up children. We have 20 kids in the waiting room. Like, we would call it. So our big surprise was that we now have to kind of go back and relook at a couple of things in terms of, do we have to call things separately, or are we still calling it as one hospital if one side is disproportionately affected?
I love that, Anne. Thanks for sharing. Yeah, we're working on a state catastrophic plan right now, and I was just in a space yesterday where there was multiple partners in the room, and there was also some of that too. And I can't remember who the gentleman's name that said it, but he worked for FEMA, and he was a big one for nothing about me without me. And I love that saying, because you're right, we get into our silos, and we can't speak for anyone else unless they're actually in the room and can speak for themselves. And so yeah, that is a big aha for sure.
Well,
Any
that saying actually comes from, the disability community, as far as that's concerned, the access and functional needs.
That's totally where he
People,
was from, Pat. He was,
yeah,
yeah, he was
yeah,
great.
yeah. So the thing that you need to remember, and I keep on remembering telling people this, is that children are your biggest group of access and functional needs. We think of access as functional needs as being, a certain amount of disability or complex medical needs, kids and stuff, and the elderly. Okay, we shove them in a corner. These are our access and functional needs, but actually your children are your biggest group of access and functional needs. because of their developmental levels.
I like that you said that, Pat, because that kind of puts a lot in perspective. Sometimes we get stuck in our box about AFN. But when you say children equal AFN, then perhaps that's a good way for folks to include them in their exercises, because then that covers that box also. So, anyone else want to share an aha moment before we move on with some polling, which I know you're excited about? All right. Maybe for time wise, let us switch to some polling and see what work have we done with implementation barriers, engagement, and value. So I'll turn it over to Julie for polls.
Okay, so this first question should have popped up. Have you implemented changes to your evacuation preparedness plan as a result of this DRC evacuation series?
And this is not about judgment, right? We just want to get a sense of where everyone is to kind of understand what's realistic in today's environment. We know many of you may wear 10 hats, same 10 people, STP we call it. But so it's not about judgment. We don't know who you are because the poll's anonymous, which is the beauty of polling. But yeah, just to get an idea of where folks are at.
Have majority said yes, operational changes at 86%. Planning was just behind that at 71%. And then we had one that said no, but we're planning to make some changes. So wonderful. And then our next poll. About barriers. What is your hospital's biggest challenge to implementation of change related to evacuation preparedness? And this one you can rank. So 1 is least challenging, 5 is most challenging.
I think we set it up, Julie, so that if you thought staffing and leadership were most challenging, you can choose both. So this is to get an idea of what are our top tiers. So if both of them or all of them are the most challenging, then you can choose all of them for your 5.
I think we have come to still. This is a bit of a new structure for me in Zoom, but the key is down at the bottom if anybody needs to scroll down. So least challenging is on the left, is that bluish color. The purple color is 2, orange is 3, teal is 4, and yellow on the right is most challenging. So you can see
Yeah, so time and competing priorities is absolutely, part of the biggest challenge. I think no matter where you are and what discipline you're dealing with these issues, it is not yet the culture of our emergency management in our nation to think about kids inclusively. And so it is a big lift.
Mhm. Well, and that speaks volumes too for what we're going to close out this session with, really, which is a resource. Because if we can provide something to you that will decrease the amount of time and that you spend on this, then that might help with that being one of the most challenging things that you put in this barrier poll right here.
And then our next poll, we've actually combined engagement and value just to make it a little easier. So the first one is, have you engaged new partners in your evacuation preparedness work since you started DRC? And the second one, did you find the format of the evacuation focus area sessions valuable? Now, we do ask that question somewhat in the session evaluation. Did you find this session valuable? But this second question here is more of overall since March of 2025, since we started the individual focus area sessions. Have you found these sessions valuable? I think we are leveled out. So I'm going to end poll, share results. So the majority of you have engaged new partners. And we asked this, and keep bringing this up, but I would be curious to know what new partners. Has anybody engaged a new partner that was a little bit of a surprise, or that they'd like to tell that's been very helpful that they'd like to tell the rest of the group about?
We are a
You know what?
quiet group, aren't we, Julie?
We really are,
I
absolutely.
feel like
Yeah.
I should I'll be the icebreaker. I'll break the silence. I think that for us, when we were completing and writing the evacuation policy that we want to, we're actually doing a game exercise in May. We're actually working with our human factors team to help us build a game that the staff can participate in to practice a horizontal evacuation from our pediatric ICU to our pediatric floor to one of our med surge areas. So we're hoping it's going to be a good game, lots of fun, but it's kind of interesting to engage them in the process because we didn't think about that before we started planning the game exercise. And we also kind of, added some other folks that we wouldn't think of to add before, like our special projects manager, who knows a lot about facilities, helped us a lot with writing the evacuation policy. So it was actually kind of cool to connect with so many different people that you know about, but you didn't really pull them into things until you needed some extra help to see, can we make this happen?
There's a lot of talent in, hospitals that can be pulled into this process. But you have to start reaching across the aisle. And Tanya, that's a great example of that. Are there any other disciplines? Maybe people feel more comfortable just, putting the different disciplines or the different partner in the chat. What type of partner?
And I love that you guys found this valuable because that's really what it's about, right? Connection and value. That was our goal. So thank you for and you could have put anything. We actually talked about this before this meeting today. It's like, oh, maybe we'll find out the truth. So we're glad that you found this DRC valuable. Thank you.
For us, just our partnership with Ethos and the evacuation equipment was new for us. So just gathering new stuff from them was one of our bigger highlights.
I will share from the last session. Their answer to this and several of the hospitals that were on that call were school systems. That was a surprise for them, and the connection of using school systems in their drills. And this was actually across the board between reunification, TICD, and Surge. They talked about using school systems, so keep that in mind as well. Awesome. Thank you.
It's like we've come to an end of our polling. Thank you so much for participating in that. And this is actually the breakout session. We were excited that we were able to fit time in for this to break out to small groups, because this was always something that was highly rated to be of value to you guys. So we're going to jump into our small groups. And again, this is a chance to share openly about what worked, what didn't, and what you're taking forward. And so I think next slide, Julie, is some of the questions that we'll be asking in our breakout session for our topics. But how will we sustain this work within our facilities? Barriers, and we've already been through a little of that, and who's missing from our tables. So we'll jump into breakout sessions, and there'll be Pat, Abby, and maybe myself, depending on how Julie splits it out with our group today. And we'll chat through these, but then come back and report out on one lesson learned, one barrier, one recommendation moving forward. So let's go into our small groups.
Enough time.
We were just talking about that, most of this work is done a conversation at a time. And that's how you do this work, a conversation at a time.
Yeah. Well, as we do going to report out, I think for one lesson learned that was shared by multiple people, is that teamwork makes the dream work, right? That kaleidoscope of perspectives is really important. And Regina put in the chat that DRC demonstrated value with the benchmarking and practice sharing outside the walls, and that she'll be exploring similar forums. And then Abby also mentioned KPEP, because that's just a cool term. Like, I just want to say to get KPEP. Kentucky Pediatric Emergency Preparedness. Is that what it stood for, Abby?
Planning preparedness.
For planning.
We're
But
easy.
it's like getting that team, the dream team together, all in the room, and making sure, that the partners are talking to each other and then pulling others in. The barrier that was mentioned in our chat as well was just that same one that was recognized in our polling, which was that time and competing priorities. So that's STP, same 10 people doing the same 10, 20 things, 30 things. I'll begin with a T. But that time is valuable, right? I know I was reading in, I think it was Quint Studer, was talking about meetings, and we all have all of these meetings that we need to go to. And the answer isn't less meetings, it's more effective meetings. And so trying to figure out what those effective meetings look like is really helpful. But he did this thing on LinkedIn, if anyone's interested, going to Quint Studer on LinkedIn. But it was interesting, some of the things that he talked about with making sure the things that we're attending are valuable, and we're not coming away in the end multitasking and not getting anything accomplished. So might help with some of that time management. And then I didn't hear a recommendation other than KPEP. Did Abby, Pat, did you, anyone else hear a recommendation as best practice?
For evacuation, I think a lot of the work is still evolving, especially when it comes to pediatrics. There are, the hospitals, American Hospital Association, your state hospital associations usually have well-established guidelines. I know in California, we have the California Hospital Association, who has a lot of resources associated with hospital evacuation. It depends on the threats in your community. In California, I mean, the emphasis is really in terms of hardening the structure against earthquake. That is our biggest threat. And it has taken decades to improve the building codes that we need in hospitals when we know that the hospitals will be able to maintain their continuity of operations with compliance to those building codes. These things are very, very difficult to get consensus on because it takes public funds and usually federal funds and state funds. And right now is not a really great time for disaster risk reduction in the United States. We've never been quite the disaster risk reduction community. In the US, we love to be response oriented in our planning and our efforts. But unfortunately, when we do that, there's, unintended consequences. And we're still living those consequences. So it's like, I think it's really important if you come away, you're working on evacuation. I hope you have your own evacuation plan for your family. I hope that you have your own family communication plan. I hope you have, a go kit. I hope you're teaching your children at a very young age how to call 911 and get them to learn CPR and later on stop the bleed, because that is what is required. Whether we're in the hospital or whether we're out in public or whether we're in our house when disaster strikes, it will always be the people right next to you, your neighbors, your coworkers, who will be there to help you. And we need a lot more of that going on right now.
Yep. Well, thanks for going into breakouts and for report out and for sticking it through almost to the end. We're going to turn it over to Julie, who is going to take us through our final slides.
Everybody. So you talked a little bit about sustaining the work within your facilities. We also want to talk about sustaining our community, our DRC community. So within your facilities, and you talk about a sustainability plan, you're looking at who it is, when, how, why, what, in the 5 W's. It's very similar to what we're working on in DRC, and how do we sustain this work that all of you have done, all of the 4 focus areas have done. How do we combine them and weave them together? Because, if you think about it as a system, it is a full system of reunification, overlaps with TICD, which overlaps with surge, which everything overlaps with evacuation. And how do you make that work? And it is that neighbor to neighbor collaboration that we have started in NC, and then even gotten into more details with DRC. We are continuing to share again the wide system, but also our individual hospital systems, sharing across those systems as well. And how do we maintain those connections beyond DRC? That's really what we're looking at right now. So we want to hear from you. What would be most helpful for you to stay connected? Feel free to throw that into the chat, or when you fill the evaluation survey out today, or the post-collaborative survey. Give us your feedback. What's going to be most helpful? Now, at the same time, I've got some slides and a few coming up that will tell you we have a plan. We are going to continue the collaborative series. It won't be immediate after June. It'll be early July or early 2027. We do have plans to continue another collaborative, and in the meantime, we have a plan to keep you engaged. So more to come on that, but just keep your wheels turning. What's going to be most helpful to you as we move forward? And as you move forward and as you look forward immediately after DRC, after today, after you're at the end of our focus area sessions, after DRC in June, until the next collaborative, what are your next steps? How are you going to sustain the work that you've been putting in? How do you continue and this continuous process improvement? What is your hospital plan to do that? And what support do you need? Again, hang on right there. So I think, Annette, you had some words of closing. So I want to turn it to you before we go into the next steps and the PPN overall plan. I want to thank you all for joining us and staying with us throughout DRC.
I'll be brief because I know you've got some slides, but I mean, I think the big thing in closing is that disasters don't respect state lines or hospital walls, right? And the relationships we've built here are just as important as the plans and tools. We always talk about plans only meaning as much as the relationships that have gone into them. And the other thing that I think about in closing is who's that lady, Rosie Rivet, with like the arm that's got the headband on, and we need you.
Right? The Rosie Riveter.
I mean, the real measure of success isn't really what happened during these sessions. It's really what happens when you go back to your organizations and you continue the work. And we talked in the breakouts about plans and processes and how that's like turning the Titanic sometimes, but that work saves lives. It really does. And so thank you to all of you for contributing to safer care for children and families during crisis. I know if we can take one more thing off the chaos plate, that's always a good day, because the chaos plate in a real incident is a big chaos plate. So thank you for staying with us. Turn it over to you, Julie.
You should have everybody should have received the first drill data collection survey in your email inbox. If you have not, please email the DNC PPN email and I will get that link to you. You should also, if you have already completed drill 1 data collection survey, you should have received drill 2 data collection survey. So both surveys are in the inboxes, and we ask that you fill that out to share what you've done, but also so that we know what has been done. And as we plan for the future, we can better plan, okay, this is what was done in DRC. We still have this work to do. So please make sure you complete those surveys. We do have 2 more DRC full collaborative sessions left. So in May and June, first Tuesday of each month, we do have the full collaborative sessions. You can use this QR code, or if you've registered before, you should have the link. So we will see you next month for that. If you were here for the Disaster Networking Collaborative, it was right before DRC. and it was 10 sessions. It was a collaborative working on C-suite buy-in and support. We talked about the medical director and emergency coordinator roles that that are good to have in the hospital for this work. And we talked about engagement in the emergency management landscape. So we've put all 10 of those sessions together for an on-demand training that you can get CME or CE credits for, or you can get a printable certificate upon completion for that. If you want to go back and review, or if you just want, I'm sorry, is that, did somebody say something? Okay. So that's there for you as well. A lot of you half of DRC has received an email to join the DRC dashboard. You can feel free to look that email up. The other half will get that email next week. And it is an option to join the PPN portal and get your DRC, your hospital's DRC dashboard. It's very helpful for QI to monitor and monitor your progress and follow your progress to see where you are, especially with your tabletop exercises and your drills, but also your team's attendance. You'll see this page that we've just taken a screenshot of. This is just the site characteristics, but it's very similar to tabletop exercise and drills, and that it gives you your hospital's data on the left and then the aggregate data from DRC on the right. And so it's really nice to be able to see where your team's progress is, and also where your DRC work and the quality improvement work that you've done throughout DRC. And then your progress tab will tell you more about the tasks and what your team has completed and what you need to do still. We talked a little bit more about how to stay informed and what to do until the next collaborative. So we have websites, and we've got the PPN website. The PPN education has a lot of modules and resources that are very helpful. The DRC resources page. And then if all else fails, you have the email address for DNC PPN at austin.utexas.edu. Email us and we'll be happy to connect you in any way that you need. Oh, and we're also on social media, so check those out. But wait, there's more. We've got hub sites, affiliate hubs, and key partners that are also there, and they want to help. Like I said in the beginning, my biggest strength is this organization and this network of systems that want children's hospitals to be prepared for the disasters so that we can take care of those kids. So you can reach out to any of these hospitals in your region. So in between June 2nd, that last collaborative session, and the next collaborative in 2027, we want to offer you a community of practice. There will be more to come, and we'll be talking about this a lot more in May and June, but we want to give you a heads up now that we're going to be having this probably August, October, and January sessions, and it's going to keep you connected. We're going to be able to still share progress, tackle those tasks that come in, and then make sure we keep that momentum up. So sustainability, having that sustainability plan, this is part of it. Don't let it drop. We've done all this work. How do we keep that sustainability? So this is our sustainability plan for you to keep you involved. So more to come on the community of practice. Here is the session evaluation. I put the link in the chat so you have that. You can also use the QR code. And also in the chat is the link to and the code to claim credit. So ZURBEZ, Zerbez, to claim credit for your CEs for this session. And then I just want to say thank you. Thank you to our planning team. Thank you to every one of you for taking care of the kids, for putting in the work, and just everything you do every single day. Thank you.